Muy buenas tardes. De parte de la
Good
conferencia.
afternoon. On behalf of the Inter-American Conference on Social Security, we welcome our participants. We welcome you to the Inter-American Center of Studies today. Today, we have constituted this very important expert panel. We're going to be discussing sensitive subjects such as migration amidst COVID-19. One of the priorities of the Inter-American Conference on Social Security is to create the right dialogue that enables us to submit advice or recommendations for public policy that's required to pay close attention to the current subjects that in which we have to pay attention. We have to think about the access to healthcare services and the principle of universality of this access for vulnerable groups. During the pandemic of COVID-19, we have had a lot of experiences correlated to social security issues. At an international level, we know that social security is one of the strongest strategies when it comes to benefits or services that are offered on social security, which is received by the population which requires these services. On the other hand, we've also been working on different subjects such as labor, social security benefits, access to pension schemes that have been matter of discussion in previous forums. We know that there's many things at stake. We have been scheduling budget allocation amidst difficult times. In the Honduran context, we know that we had to give back the beneficiaries their pension ahead of time. So, and today we want to thank the participants for being with us. Our core researcher in the subject of migration, Dr. Martinelli, and all the participants. You will have the opportunity during the Q&A to contribute and give us your questions. During this initial activity, it is extremely important for us to highlight that this debate or this interactive remote scenario that the conference offers happens with certain frequency. In these sessions, we discuss different subjects. You, with your feedback, have given us the stimulation or incentives to share the experiences of different member states or countries to strengthen on a day-to-day basis social security for the Americas. Now, I'm going to introduce Edgar Daniel Manchinelli. He's an expert in the Conference on Social Security, Health, and Other Matters. He has a PhD on social sciences with an area of expertise by Colmex on social science. He's also a candidate to be part of the research center of CONACYT. He is an expert in migration debates about in Central America and the information systems about migration and institutional limits. These have been budgeted by the Human Commission or the Human Rights Commission. These efforts were led by Sylvia Gugel from Colmex. He was also a consultant with the nonprofit or NGO GIZ from the German government. He worked in two projects, the Mempedo project in Mexico about education for migrant groups, and another project about labor integration, entrepreneurial activity for vulnerable groups in Jalisco and Querétaro. He has published different documents about migration and corruption, amongst other subjects, and worked in different forums of international level. Today, he is part of the session. He's going to be working with us during the coordination of this important webinar. I hope you profit from this experience. We're going to be here with you with each session, participating in the phase of Q&A or questions, which will receive an answer. Any questions that you want to pose will lead us to profit all our economies. Thank you very much, Mr. Manchinelli. The floor is yours. Thank you so much. Good afternoon to all of you. We welcome each and everyone. I am Dr. Manchinelli. I'm coordinating the webinar called Migration and Health Amidst COVID-19, which has been coordinated by the Inter-American Center on the Center of Studies on Social Security through the Inter-American Conference on Social Security. The objective of this webinar is to share expert experiences from top keynote speakers in the healthcare service analyzing feasible health policies for member states of the seas. I'll give you the context. Many of the experts who are joining us know very well that there's people that are subjects that are not regulated subjects, who are immigrants that have suffered restrictions when we speak of access to health, even before the pandemic. This is due to different reasons, mainly because they're excluded, they're marginalized from society, and economic constraints amidst among other factors. So there's a high index of vulnerability when it comes to health for these groups, correlating this with poverty of economic resources, isolation, abandonment amidst peril or hazardous conditions. This vulnerability eh, has become even deeper amidst the pandemic and COVID-19. In countries of origin transit of these immigrants through the Americas and the Caribbean, this immigration has something that we felt dearly, creating an sanitary or health crisis that threatens the health of these vulnerable groups. That's why it's important to listen to this session. We will be talking about the adverse condition that lead us to think and be mindful about building and submitting recommendations that will then generate public policies to mitigate the problematic that we face with the immigrant population, subjects who are in immigration being unregulated. Something that I heard in the Cesar Infantes conference is something that I'll recall, and I thank the presence of Kaholi and Deschak, both professors. We thank you for being here. We thank Donatio Gonzalez and Elian Martinez as well. Thank you, professors. As scholars, I remember that during your presentations, we're going to give you 20 minutes for each presentation. As speakers, that's the time. First of all, we have Dr. Cesar Infante, who is a surgeon physician who achieved his degree thanks to the Autonomous University of Morelos, Master's in Science in Healthcare fields, thanks to the National Institute of Public Health. And during his master's, he explored other subjects as rejection that is suffered by HIV patients in different demographic layers of the population. He studied his PhD in philosophy in the University of London, England, with his dissertation associated to AIDS, immigration, and the border of Mexico and Guatemala. Since 2000, he's been researching immigration and health, HIV, immigration, human rights, and since 2002, he's been working in the research center of the INSP as part of the group of researchers who are analyzing what's happening with the vulnerable groups in their sexual and activities in HIV situations. He's been the director of HIV for the United Nations AIDS Alliance, and since 2010, he's been part of the national researchers. He's the joint chairman of the unit that studies health, called INSP. This agency promotes the fight and the understanding of the challenges that we face in with HIV in Central America and the Americas. He's been working on partnerships that lead us to achieve improvement of health in Argentina, Colombia, Nicaragua, El Salvador, Guatemala, in the southern border of Mexico. He's worked with a network of housing systems for the vulnerable in Ixtepec, San Luis Potosí, Saltillo, Nuevo Laredo, and other areas such as Tijuana. As part of these projects, he has been provided technical assistance to strengthen the development of the information systems that we work with, such as systems used in HR for mediation, health, human rights, and generating findings or evidence to document this information to draft public policies and strengthen the services in health. What he has written is called Migration and Health by Cesar Infantes, the perspectives and the grounds for Latin America. The floor is his. Hello, good afternoon. I can't activate or enable my video, but I welcome you and I hope you're doing fine. I hope you can hear me loud and clear. Yes, or we can hear you loud and clear. Perfect. So are you going to share my presentation or can I share my screen? You can share your screen. Okay. Okay, 1 second, please.
Ok. Bueno, yo no la veo. ¿Ustedes la ven?
Okay, I don't see my slideshow. Can you? Yes, we can. I can't see it though. I hope you can. We can follow you. Thank you so much for inviting me. It's been a pleasure for me to continue with this dialogue about health migration and with our colleagues that have been part of this effort for many, many years. You're dear to me, Ayut Yetza, and another expert who's Caroline. We're going to be dealing with relevant subjects altogether. I'll be brief. I'll share the general scope of my understanding of migration and health, so my colleagues have their time. They're going to share the data of their projects, their ongoing projects, and projects that have been well created before the pandemic, amidst the COVID pandemic, and so on. I'll probably consume less time than I have, but maybe it'll give me more time for questions. This work you see mirrors the hard work that we've developed in the Institute INSP. We started working with this project with Mr. Mario Bluffman back in '99 to date. We've developed a series of research projects with a mission in action. We incorporate the participation of stakeholders, the civil society, other agencies, healthcare benefits, or health institutions at local level, and other important stakeholders that work closely to issues such as migration and health. We must mention important colleagues, Ana Leiva Flores, coordinating the studies of migration, pioneer in the research projects about migration and health, Frida Quintino, another colleague of ours, and Cristian Torres, who's now working in Chile. Okay, we're going to see the general content, how migration is understood and analyzed in Latin America, its migration and health. How do we draft policies about health and migration? I'll give you the concrete, solid example of the Mexican scenario about the results and implementation of these policies. And I'll be talking a little bit about the concepts or what frames and what gives us that frame of reference that enables the drafting of these policies, health policies. But not in all economies do we have the same response because the world is ever changing and complex with migration and its impact. The impact of migration and health is very important. The following data in this slide dates back to 2018. These are the books of migration and remittances fact book. And in this fact book, I think that it has not suffered important amendments or changes there, but we're going to see it. We're going to analyze the specific mobility. In Mexico, we have 232 million people living abroad in a country that's different to their country of birth. We see the movement of people internally in their nations and others. The remittances are a very important factor to consider in correlation to the impact of migration. Each semester, we've heard, at least in Mexico, that we're breaking records of remittances in economic, money that's being sent from the US by immigrants who have sent their money to Mexico. And along the same lines, I'll tell you that it's extremely important. We see the similar pattern in El Salvador and Guatemala. We see the GDP and how remittances are a great percentage of it. In correlation to migration or the corridor of the Mexican migration corridor, that belt in Mexico and the US is the corridor that has greater transit of immigrants. And here, this leads us to think about how important the pandemic effect has been. Now, I think it's very important for us to look back and think about those vulnerable groups that are not visible, that are not represented in our policies, along with the strategies. Other colleagues will explain this later on. There's groups that are facing difficulties when it comes to the exercise of the rights, the exercise that they have to receive the benefits of the healthcare system. COVID has transformed the dynamism of mobility and response. as well as the services that are provided to give the people attention and the humanitarian strategies that we needed to give in houses and other networks for housing immigrants. These are points that enable debate. We've seen how COVID accentuates the difficulties that our people have faced to receive the benefits of services. Due to COVID, there's a certain networks of housing for immigrants that have been shut down, and the dynamism of this have generated a negative impact on health. Now, in that regard, I'll say that the closure of these housing networks have made the immigrants find other places that are not clean, disinfected, safe for them, where there's no social distancing or drinking water access even, nor medication to prevent any condition. Without doubt, the COVID has has emphasized or has made us pinpoint that there's a lack of fairness, there's a lack of balance when it comes to having access to the basic satisfaction of needs. Imagine this transferred to the vulnerable groups of society. This all has had an impact. In the region, if we think of Latin America, during the last 3 decades, there has been a very important change in the dynamism of the immigration and its flow. There is an increment in the flow of people since that dates back from 2010, 2018. Overall, you see the immigration between continents. There's our counterparts from Haiti. The immigrants are coming to Mexico. Some people have left their economies, going to other economies in the region. So they've used different methods for this purpose. People's immigration, for example, from Venezuela to Colombia, from Venezuela to Chile. I mean, we've seen how it's all branched out, and we've analyzed the profiles of the immigrants. Now, recently, what I've had to analyze was some press conference releases or announcements with regards to the changes, not only the changes in the incremental numbers of the transit of our people, or we've also been analyzing hard data of data phenomenons of the caravans, the migrants caravans that date back to 2018. I think that in 2020 there was no caravan of people in their displacement. There's a lot of petitions or being submitted in Mexico. People are seeking asylum. The secretary, Mr. Encinas, the head of that ministry, was analyzing to draft some sort of decree that dates back to 2013. But this year, we had 51,600 and some petitions of asylum during this year. So we're not just talking about immigrants in transit. We're talking about this immigration. There's immigrants being detained in the northern border. They have to deal with all the bulk paperwork to have access to the US. There's provisions and agreements and treaties between both nations with our neighbor in the north. There's displacement of people due to the conditions of great violence that are not only suffered in Central America, but in the center of the country. So this has led to incremental numbers of asylum petitions from countries such as Venezuela, Cuba, amongst others mainly. But there's an increment in the remittance reception in the economies. And I'll say also that, immigration also has taken a different twist. There's more females having to move and displace themselves and have to take the step forward and move in transit. It's not only males who are migrating, there's also female numbers that's changing. Which are in this matrix, we see what determines mobility in LATAM. Well, we know it's poverty, economic crisis, political and social crisis. Violence is one of the factors and that determines. We could add a column that could be COVID here in this matrix, but COVID, what I think now is it's not only COVID and the pandemic itself, it's just these three conditions. And, there's more of their spectrum in poverty, economic crisis, political, social crisis, and violence that are factors that determine, and we add COVID to this, making the whole phenomenon that we're studying a bit more complex. So we analyze the colors that we have in each column, that there's differences in each nation, but these are the conditions that we highlight or mark in each region that make a greater number of people have to move from their original nations. In Mexico, you see that there's an important number, and that's in the column of violence. This also will make us think and be mindful about the mobility of the different groups that we study, not only the immigrants in transit who currently, I mean, we have acknowledged their presence. We have seen these people in transit and analyzed the speech of the immigrants in transit. We analyze politics, but some of the groups are being left aside, like the temporary workers for the field or farm workers, sexual workers, or people who are in immigrants or displaced and their status is of refugees and other residents in the population at the border. We can't just think about one group in which we can have all these subgroups. We have to say how to meet the needs of each group, and the needs of each group you see in this matrix is different. The dynamism of their mobility is different, and in the area they're present in is different, and it depends on different properties. And also, I believe that it's important to consider that the mobility and the dynamism of the mobility of the different groups that I've mentioned are different to circular migrations. There's migrations that we call, or that we think that immigrants in transit used to take 3 months or 90 days to finish their journey in transit, and those times have changed a lot. The time interval has changed for displaced and refugees, for others. So this is an important a problem, because there's people who are also residents at borderlines that move and cross the border in transit due to commerce, education, and other issues. What happens when migration or immigrants transit through Mexico? There's transit is mainly happening through Central America, people from Haiti, Venezuela, Cuba, and the Caribbean. We have documented with the research that we've been part of, we know that there's immigrants from 75 economies. Recently, yesterday, the Undersecretary Encinas spoke about having people coming by from 90 economies, 90 countries from all the world almost. Their petition is asylum. They seek asylum. It's important to consider the numbers. We calculate that the number of people that access Mexico in a illegal way or unlawful way, as to say, without documents. I mean, those are the numbers, but we don't have official data. We don't have the common denominators to estimate, to compare, or to tally the impact on health on the locals in population. How badly has COVID affected these vulnerable groups of migrants in comparison to the locals in those regions? We know that there's no common denominator to stipulate, but what traditionally has been said, the numbers are rounded in 350,000, 750,000 who access this country without regulated or documents. So if we think about COVID, the definition that the Ministry of Health specified to define a COVID case of an immigrant depends on the time frame or time interval in which the person that's in immigration stays in Mexico. But they haven't considered or pointed at other factors. I mean, they don't know if these people have their documents or not. And they're subject of analysis. When we think about the variables and think about the people who are in transit in the country of origin, then if we know the origin, we can have a number that's really representative in that universe of immigrants, whether they have their documents and are in transit in Mexico. The drafting policies is something that has to do with certain concepts. And when we think about drafting, we think about the significance that exists about the international border lines, the borders delimitation, or the borders in the following terms, or a border marks a limit, the difference between one economy and the other. And the border is correlated to sovereignty, autonomy, self-determination. And in the legal realm, we have to think about who like if we think about countries, some economies think, okay, this subject is legal, this one's illegal, who deserves the benefit of this right and who doesn't. I don't know if you remember when if we analyze history, when we thought about the caravans of immigrants that passed by, some people spoke about an invasion of immigrants that were trying to affect the sovereignty of an economy, and that has nothing to do with a country's sovereignty, according to my understanding. But there was some in saying that it was a clear invasion. All of this has had a clear impact in the ways in which countries draft their policies, their internal policies, in correlation to who has access to health benefits or not. This has also, it's correlated to understanding the different grounds or perspectives. I mean, it changes region by region, but here I point out some examples. In this slide, I have national security. National security is something that would, in Mexican context, we know national security, we've heard the speech and the laws and regulations, all the provisions and the speech about what's happening with international treaties that should be focused on human rights. But apparently, the way in which they've tried to implement it, take to a positive right or the exercise of law to some sort of, I mean, design and policy, we have to think about controlling and eradicating disease. Law is like the controls, you know, and it's correlated directly to social problematics. Now, we think about the economic development. That's another point. I mean, we think about the health of our workers, the risks at work, correlating it to economic development. We have to adopt the right laws and regulations to meet the standards of human rights. Think about human rights for immigrants. How do they have access to preventive services and health in general to solve their health issues? Another analysis of public health and national security, as I've mentioned, leads me to point out the number of immigrants with the vectors and the incremental numbers of spread of immigrants. There is greater presence of healthcare problems and spread of infections. Now, after seeing this, we can understand that immigrants are seen as the cause or responsible, liable of the spread of healthcare issues. So the only explanation that we have to understand the problems of health that we're facing is we have to understand what's happening with the locals and those people who are mobile in transit and how they impact the spread. This type of analysis has led economies to close their borders, stop the flow of people amongst nations, and amidst COVID-19 and the pandemic, we've seen it clearly happen. There's a constraint of the transit of people and journeys of our people, and as a response, there's been responses that have been applauded by important sectors of our population as a preventive measure, trying to prevent the spread. If nobody corrects me, I think is something that's applied in all economies in the world. Now, what has surged is we have the surge of variants of COVID. So there's more and more appearing more and more often. But let's say it's not just a subject that's affecting the mobility of the immigrants that are these people who are in transit through our country or Mexico. I'll give you some examples about how policies are defined, drafted, and how these have to satisfy and meet the needs and cover the needs of the immigrants in health. I know that there's risk in this project when we're trying to be very general in scope and trying to see what happens in the region of the Andes, Bolivia, Peru, and other regions in Venezuela. We see the response from Chile and the Chilean government and how they've been capable of giving services to those immigrant groups in the central area in South America. We are trying to facilitate the primary healthcare services, ER, children's health, health during pregnancy, sexual health, and reproductive health. This is all based on human rights. That's substantiated by the pillars of health. That's what frames this as reference. We focus on human rights and the relevance of health, the right healthcare system, to have a decline on the risks that we are facing in the health field. This is something that we've seen in Central American regions and in Mexico. These responses are for immigrants who are in transit. What we can see here is that there's limitations. The coverage of the services is constrained. What we can provide, before Insabi existed, we have the popular insurance services that had its constraints because of the administration systems that petitioned the beneficiary to send a bulk package of documents. And in Sabi, there might be some contradictions according to my understanding and my perspective is that some say that it's not necessary to speak about the immigrant groups in particular. I mean, we're talking about people that might not, that don't have access to Social Security, but however, if you want to register as part of the INSABI, a healthcare institute, I mean, the INSABI will ask the petitioner for an ID specifying their status or citizenship, proving whether birth or certificate that they're well from the country or not, so that Tonatu will be speaking about another example. It's a very important example. He's going to discuss about what happens with Mexican immigrants in the U.S. and the services being provided in the Mexican-U.S. border. We have a political interest there in that case, important cases that are relevant for binational actions. Both countries participate, both governments are working together, NGOs are working together, universities are involved as stakeholders, and all of this is mirrored in the diplomatic headquarters or venues, consulates, and other embassies in which immigrants receive primary healthcare services. There's different binational treaties or agreements that try to tackle and have a decline or infectious spread of diseases. We have different initiatives that call our attention. What catches our attention at this moment is, and I'd say the following is a very important point of debate. We want to fight for the right to healthcare services in which, well, it seems as if health was not just a right, but what happens in Mexico? We see that there is in our Constitution, in the General Health Care Act, and in our Constitution, our articles speak for themselves. The access to health is a right. It's a health for those who are locals, part of the citizenship, and non-Mexicans who are in national territory. I'm not going to stop there. That's Article 1 for the first article in our Constitution. The fourth article in our Constitution, recently adjusted or amendment, all people have the right to be protected by our law in health. The fourth article speaks about the access by any person or subject to healthcare services in Mexico. And there's Article 33, in which the wording is the following. You have 2 minutes, sir. Okay, perfect. I'll give closure. You have this as part of your rights and guarantees in the Constitution. So I was talking about the institutional programs or schemes from the National Institute for Health. There we specify that everybody should have access. We still have many petitions, but what's happening here in reality, the immigrants who are those people in transit have certain problems of health that have been prevalent in affect the health in general. They have received some services in NGOs and other networks that provide services. We've tried to find different channels to give a response and give these people the needs or the services. And we see the law that's in effect, the laws and regulations that are in effect, and that should be given by that law. But what do we suggest? The next suggestion is when we analyze health and immigration, correlating it to rights, analyzing the vulnerability context of our people that have an impact on the way we expose and manage risky situations and the results of health. I mean, we depend on the reaction or response of services policies, which is extremely important in all the agencies. Now, These points are left for you in this slide. I shared that my slideshow with my colleagues. You can have access to it. And I'll just ask you to follow me and pay attention to the last points. There's different levels of government and actions from civil society that should not signify that there's a loss of responsibilities or level of action by the federal government. We have to think about organized civil actions that could lead us to have a positive impact on those immigrants that are suffering in living the COVID experience. We have a network of housing systems for immigrants that we must strengthen. Civil society in action strengthens because we are the first responders that can help and satisfy the needs of our immigrants. Thank you very much.
Thank you so much, Doctor. I would like to highlight certain points that you just mentioned. I have some notes written down. So just taking a look at the differentiation of the needs that immigrants have. And I would also like to add the different, let's say, health needs for each age group. And just according to everything that you just stated, and I think that it is very interesting to get into the meanings and also the meanings that are related to this xenophobic discrimination that have been all over the world, specifically related to immigration, irregular immigration more particularly. During the COVID-19 pandemic, this type of social separation was even more evident. We saw a lot of citizens who were not able to move around. So I believe that there is a discussion that could be divided into two categories. The very first one has to do with the human rights position and the xenophobic position. So I think that it is important in all over the world, specifically in Mexico. This is a very important area of passage in terms of immigration. So we have these two standpoints that many times are seen, whether in the southern border, in the state of Chiapas, this politicization policy, and also discourse and in many laws. We see that access to health services for this population, and also they have this other access to people, and we know that this is related to this human rights discourse, but at the same time, we know that we need to find this security policy. And as well, I would like to thank Mrs. Lisa Bojorquez. She is responsible for public research, specifically on social structure and health matters, specifically for mental health, health overall, and immigration, access to health services, and also related practices, health-related practices. She's also a general doctor. She has worked in promoting health in rural areas in Mexico. From 2007 to 2010, she was the head of epidemiological research at the General Directorate of Epidemiology in the Ministry of Health in Mexico. She's also taking part in some studies in the schools of research in Mexico. She is currently part of the immigration service conducted at the borders of Mexico. She's also working also on research on epidemiology and migrants, and well, specifically in this pandemic situation, and also the development of a model to enable access of immigrants to health services, specifically mental service. So her presentation is public policies and research in Mexico. So I'll hand it over to you, Doctor. Thank you so much. Good afternoon. Thank you so much for this invitation. I would like to share my screen. So my presentation today is just, let's say, the continuation of what Dr. Infante was sharing. I have some results of a research that we conducted all together. And I would like to focus on how public policies in terms of immigration and health have developed in Mexico, and also to understand what are the main determining factors. And before we start, I would like to emphasize that the comment that was shared at the very beginning on the significance of social security in this aspect. And I agree that ideally, health should be one of the main elements that should be covered or addressed from social security and not from other standpoints. That would be the most efficient way to do so, to address healthcare issues. And also the fact that immigrants do not have access to the social security, including these healthcare services. This is one of the main issues that we find in immigration in Mexico and all over the world. So, according to different theories and authors, the answer given by a healthcare system, when I say health, I mean the main public services that have been defined or promoted by the government, but we may address others by the civil society and or others. So the answer given to this immigration phenomena are pretty much caused by certain elements. One of these ones is this immigration tradition in terms of immigration in the country. Why is this important? Well, when we change this immigration flow, we may have a change in this healthcare response. And also concerning this, we address representations, all agents that are involved in the development and definition of a public policy. As a matter of fact, we have a way to represent this public policy issue and also what are its constituent elements. It is one of the main situations happening here is to take into account what are these agents taking into account when it comes to defining a public policy. What is an immigrant? What is immigration? What is it that they think when they think of immigration? All of this matters. And this is important for this immigration phenomenon. So we know that immigration and other policies have other matters such as the fact of having this immigration condition documented, undocumented, specifically whenever we see refugees. And this is going to have an impact on the possibility of a person having access to certain healthcare services. And to the extent that this is related appropriately with the proper interaction, then it is going to be easier to have access to these services. Or if these two types of policies are developed to have these two types of services, then we're going to have this, let's say, perverse objective. But we know that immigration and health care policies are somehow related to one another. Also, last but not least, political, national, and international relationships at all levels. When we talk about municipal, state, federal, it all depends on the country. This also has to do with the response given by the healthcare system to this immigration situation. So it is quite interesting to, well, talk about this comparison proposed by Cesar in the different regions in Latin America. And we may start thinking about how or the way these responses are also addressed in international relations in this case. In the case of Mexico, this is quite clear. A lot of these answers in terms of immigration and healthcare by the Mexican government is also closely related to the public policies of the US because we are very close to them. We know that the US somehow holds back certain immigration. They think of immigration as an issue. So as Mexico, they respond in a certain way. They have a capacity to somehow identify and relate what happens in the healthcare system and also link it towards what's going on in the immigration policy. We could talk about policy related to immigration from Venezuela and many others. But right now, I'm not going to be focusing on that, but perhaps these are the main ones. We may perhaps address this at a later time, but well, this is the experience from other colleagues as well. In the case of Mexico, the case that I'm going to be focusing on right now. Before 2018, 2019, I'm talking about this year because we're talking about the previous term, presidential term. And well, we analyzed these policies in terms of health and immigration in Mexico. And let's say the cutoff point was specifically this period. So I would like to start addressing what was going on at the time. I would like to stress on this immigration tradition and the representation of what is immigration used to influence on the policies related to the health of immigrants. So if we take a look at these public policies, immigration during this period, let's say from 2015 to 2019, or even in the past decade, the representation or what we address there in terms of immigrants is something that we see, let's say, specifically with Mexicans in the US who have been, let's say, forcibly displaced or deported. And this is something that we see all the time in public policies. So we are going to start just protecting Mexicans, their health in the US. And of course, we know that we have had all kinds of, let's say, policies. We're trying to have this repatriation assistance. We also have all types of, let's say, windows where we can provide this type of services. And we can also help Mexicans navigate through the American healthcare system just for them to learn. Also, they can just navigate through a system that is very complex. And also these modules of human repatriation, what they do is that they receive Mexicans whenever they are being repatriated from the US. We provide them with some sort of, let's say, assistance. We provide them healthcare in terms of, let's say, we promote healthcare and we provide this kind of services whenever there is a need to get this type of services. So these policies were mainly developed during this period, but there was barely a mention on this type of mobility during that period. And the second group of the population was Central American immigrants who were only passing by, they were in transit. And this policy was specifically for a population in transit. So from that view, it makes sense that the main healthcare response is this, what we call popular access to this healthcare system for only 90 months or 3 months in Mexico, 90 days. We would include them in this, what we call popular service in Mexico, and then they could have access to this healthcare system. But what happens when they get to the US, if they are returned to their home countries, then they're going to become an issue for Mexico, to put it that way, and then they're going to stay here for 3 months. Obviously, this policy had a lot of limitations. Many times we had criticized the fact that a lot of diseases require, well, services, healthcare services for over 90 days. In this case, of course, we need also other points of attention and care. We're talking about in transit and a maximum time limit of 3 months. This was specifically for women who decided not to be affiliated until their delivery date, until they were due in the event a woman was, let's say, pregnant. So we would leave this 90 days until the end because the public policy would have this impact. I'm talking about women who were born in countries, let's say, who were not born in Mexico. They were just in transit and they would stay in the country for periods longer than expected. This is what happened in this period that I'm mentioning right now. In 2018, 19, or even before that, in 2016, with the arrival of people from Haiti to Mexico, mainly in 2018, 2019, with the arrival of what we call the migrant caravan, and that also somehow just happened at the same time that we changed our presidential term. So we developed all of these public policies specifically for immigrants who are passing through Mexico, specifically bound to the US. So in this case, we had a concentration of people under suboptimal or subpar conditions. We had these temporary shelters, and the policies that were developed at the time, almost all of them were what we call response policies or emergency response policies, and these are based on the situation that happened first in Colombia and other countries with a lot of contingent groups coming from Venezuela. So this change or shift in the immigration flow, the mobility, the type of mobility that we saw was related to a change in the representation on what really mattered, and a very different policy was created for a different sector of the population. At the same time, we saw a very radical change, and now it all has to do with persons in transit in Mexico bound to the US, caravans of migrants, and that's precisely how we have been working with these public policies as of the time. So these services provided to this contingent, specifically humanitarian assistance, all of this is mainly based on this idea of having just temporary emergency situation. I mean, I'm not saying that these are not important and that we need to address them, but I'm starting to think about, let's say, immigration policies for migrants in those countries where they are mainly used to getting immigrants, such as, let's say, the US, Canada, and other countries in other areas of the world. Many policies in terms of healthcare provision somehow integrate. Well, I also have to mention and note that there are some policies that are quite restrictive. Well, anyway, we need to allow and enable immigrants for them to be able to have access to these healthcare systems. So at the time, ever since in Mexico, we have seen this in-transit population. These are individuals who are in an emergency situation. Why? Well, because we know that we need to start just deploying these services specifically for epidemiology services and the migrant population that just started to come in 2019. These were migrants who got into Mexico, into the country, and then we were the first response in terms of providing this type of humanitarian assistance. This is not for the long run. This is just for the short and medium run. So we need to start just thinking about this healthcare coverage that we need to offer, and we need to assume that these individuals are going to have some sort of ID for them to be able to have access to these services, but we are not including any other policy related to their inclusion. A more recent analysis that we just conducted after this COVID-19 pandemic hit, I do not know if you are aware of this article by the Population Council, but well, what we did is that we analyzed the policies that had been issued as a response to this pandemic. So we started to make some searches at the official Gazette of Mexico. This is where we publish oral, let's say, orders, decrees, and laws, and we pass them all. And all of, well, we try to look for all of those that had been issued by the National Immigration Institute for 5 states that are also part of the northern border to the US, where we see the largest groups of immigrants, and also in 9 municipalities where we see the highest concentration of these individuals. And well, now we started to take a look at the different policies that were issued specifically to address the pandemic, not really the other ones that I was mentioning before, but well, our main findings from this research is that we found 6 gaps in these policies. The main framework for us to run this analysis is mainly based on 2 pillars that are evaluating how inclusive are these immigration policies in these countries. One of them is the MIPEX index that is developed by a consortium or of European service. And somehow we need to have some sort of benchmarking of the different public healthcare policies across different countries, and also with what has to do with its inclusion. Well, we just had this index in Europe, but in 2020 or 2021, there was a publication where countries from other regions, specifically from Latin America, were included, specifically Mexico, and this addressed a series of different dimensions and aspects. These are the aspects that we started to analyze. This is a framework that was established by Filip Aladovsky, and he mentioned that in order to ensure access to healthcare services by immigrants, we need to establish these policies. And well, this is where we found these gaps. And from the documents that we analyzed, only a minority addressed this matter of immigrants. So whenever we talk about these public policies that have been issued by the Mexican government as a response to COVID, out of those documents, very few of them just refer to this immigration situation. I would say that even less than 10% would address the situation. Obviously, one of the main responses, or well, one of the main actions that we took was just closing borders. This, of course, had an impact on immigrants and immigration. And whenever we started analyzing these documents that had been issued by state governments and municipality governments, we just started to take a look at the concentration of these persons. So the fact that we just really took a look at all of these documents in response to this COVID-19 pandemic, and the fact that these policies did not include anything related to immigrants just allowed us to really tell that they were not addressing the issue. We have groups as part of this policy that are not visible. Like I mentioned, we are, let's say, investing our time in this regard, and we believe that these immigrants are only in transit persons or some people who are just requesting some sort of assistance as refugees. They have been staying at temporary shelters. Some of them have been around for about a year or more. And members from these groups who are not living in shelters but in a community, these are not even included or taken into account. And immigrants who would like to stay in Mexico, they are not mentioned. And Mexicans who are, let's say, very significant in the country, Mexicans who are just migrating to the US and who are deported back to Mexico. So we have certain groups in particular that had to be taken into account. So even though Mexico somehow allows and grants this right to have access to a healthcare system, in these public policy documents that we analyzed, this is not explicitly stated. Other documents refer to this situation, but these particular ones are not referring to that, and these are not specifying how this is going to be somehow assured. So we also need to have interpreters for those individuals who do not speak Spanish. And in Mexico, although most of the migrants come from Latin American countries who speak Spanish, we also have a high number of immigrants who come from IT, for instance, from Haiti or other countries. I even see that, let's say, about 90 countries are also, let's say, from other countries who do not speak Spanish. We also see immigrants from indigenous groups who do not necessarily speak Spanish. So we are not really trying to get healthcare statistics or information beyond COVID. Of course, we were just addressing COVID-19 documents, but this does not mean that we do not have any other type of healthcare issues. But I just wanted to highlight the fact that there are many health issues that are just going on in addition to COVID. So these policies are mainly focused on preventing this COVID-19 infection and spread. We barely have provisions for other topics. We have mental health issues addressed, but just barely. And also, how are we going to start funding these policies? Who is going to be the owner? Or what are the incentives that we have in order for us to be able to just enforce these policies? What are going to be the fines or the goals and objectives that are going to be related to these services provided to migrants? So all of this needs to be part of these policies. So we need to assume that there are a lot of loopholes, a lot of gaps in terms of the public policy implementation. At first, you read them, they are pretty much inclusive. You really understand that they are trying to really protect this right to have access to healthcare services. But once we get into the details, we see that its implementation is not really inclusive. And because of this, in this MITEX report that I was mentioning, I saw a list of countries who state that they have public policies that are, let's say, somehow deemed inclusive. But if you really get into the details of these policies, you're going to see a lot of loopholes that really just allow you to tell that these policies are not being put in practice, really. So these are the findings of what I wanted to share with you. All of this is related to what we were just addressing in terms of other previous policies. And this is also related to the fact that in Mexico, we do not really know that we're not just a country of origin. We are not just an in-transit country. No, we are also a country of destination. And we do have the public policies in terms of immigration and healthcare provision, and we need to really start implementing them. So thank you so much. Thank you so much, doctor, for your presentation. I would like to send out some points as well. With what you just mentioned, we may think about the fact that the Mexican state has been using and abusing all of these public policies. Maybe we need to somehow expand them for the long run. And the last part, where you address the gaps, I found them very interesting. It's been 4 or 5 years when I started just conducting a research on state laws on immigration, and we realized that many states refer to, let's say, migrants such as, let's say, dwellers from Guanajuato or Sonora states or other states. But we noticed that's the only type of immigrants that they were somehow contemplating. So there are some states that started to really including transit persons. I remember one of them, that was the law for the state of Mexico. And I believe that, do you address something that was somehow related to the previous presentation, meaning that we are not really considering the diversity of all of these immigrant groups? This is very important for healthcare service provision. So let's continue. We have Dr. and Miss Caroline Benchak. She has a degree in cross-disciplinary studies for global health by the Salisbury University in the US. She is also a public health teacher. She focuses on nutrition by the National Public Health Institute in Mexico. She is also part of the international program Fulbright Garcia Robles. Caroline is the co-author of several publications focusing on immigration and healthcare provision, specifically for access to food and healthcare services and human rights. She's a co-founder of an international working group on food security and mobility. She is a member of research networks such as USAID and the International Immigration Organization of the UN. She's also part of the Universidad Iberoamericana in Mexico, and she also addresses the global governance for healthcare matters facing the COVID-19 pandemic in immigration context. She's also a professional lecturer. Caroline has also worked in several areas such as the coordination of healthcare programs and security for agricultural workers and migrants in the US, and also the healthcare provision to individuals in the Marshall Islands in Argentina. So her presentation is well being and immigration in a COVID pandemic time. And well, I would like to pass the floor to Mrs. Caroline. So thank you so much. Good afternoon, everyone. Can you hear me? Yes, loud and clear. All right, I will share my screen. Good afternoon, everyone. Thank you so much for having me here. I feel really glad to be able to share today with you with such distinguished colleagues and guests. I would just like to thank you for actually training me and educating me on this subject. So in addition to that, I would like to thank everyone for joining us today. So I would like to tell you in the next 20 minutes what well-being and immigration are like in COVID-19 times, mainly focusing on food security. So this is the agenda that we have for this presentation. We are going to focus mainly on universal human rights and how we can frame them in this international legal framework, also in the Mexican context, and I will be focusing also in, well, I can tell you that I have got a lot of education in Mexico and the US. This is why I'm mainly focused on that. And also we're going to address well-being in this immigration process. I will not really get into a lot of detail because we had a great background presentation by my colleagues here. So before COVID-19, we were addressing the situation that we had and about what we know regarding certain issues that we had addressed specifically for what happened with having access to food security as an important part and for us to be able to just allow this degree of care for immigrants. And then we started to address what happens in this contingency caused by COVID-19. We have not yet really overcome the situation. So we were addressing, let's say, the minimum optimal lifestyle of immigrants and also areas where we can provide them with assistance and also other matters. Are going to have some final comments and recommendations. So let's step back a little and address healthcare. I mean, healthcare as such is not just having access to this type of services, but just having an adequate, appropriate standard of living. And this is something that can allow us to somehow be in a situation of well-being. And having this appropriate standard of living, that is a right, and that started many years ago from the Universal Declaration of Human Rights, when we saw this declared as a universal right that mainly includes food, access to food, and necessary social services. And furthermore, we also highlighted priority given to motherhood and childhood. And we saw this in pretty much all countries in the world in terms of the legal framework. To date, we see the special situation of Mexico in the political constitution of the United Mexican States in section 4, as already referred to by Cesar. It specifically provides for that all individuals are entitled to have nutritious food, quality food, sufficient food, and the state shall provide this. Other laws such as the Blanc population provides for, since 2011, that immigrants have been recognized regardless of their immigration status or country of origin. They are also subject to the Mexican laws. We have just mentioned this many, many times before. In addition to this immigrant situation, we also list other public stakeholders just for us to be able to make sure that we can just protect and enforce this right of everyone who may be in Mexico, specifically for kinds of immigrants. So immigration is linked somehow with all of the SDGs of the 2030 agenda issued by the UN. Why? Because we know that immigration as such is not a discipline, but it is a condition, a status of an individual, and that's the situation. And we may intertwine the different goals, just like the objective number 2, which is no hunger of these SDGs. So these SDGs are not leaving anyone behind. That's the main motto of this SDGs. And this specifically just to enforce human rights and also to do it in equal conditions. And we can focus mainly on 2 of them. SDG number 2 is zero hunger. We need to just end hunger and ensure access of everyone, particularly those in a situation of vulnerability, to a nutritious, sufficient, and healthy food. And whenever we address access, well, this is a word that is going to come up a lot. And also SDG number 10, this is related to what we were addressing as well. And we need to just minimize inequality. And according to this SDG, we see that all of these rights need to be just enforced equally for everyone. including immigrants, regardless of their country of origin, by including the individual socially, economically, and politically, regardless of their conditions, and also ensuring equal opportunities. We know that we can somehow use this SDGs as a roadmap. So specifically in SDG number 10, we saw that this led to this Declaration of New York on refugees and immigrants. And actually we saw two more compacts that were somehow arising from this declaration. The first one was published in 2018, and actually we must know that Mexico was one of the co-facilitators of this global compact for safe and secure immigration. This is mainly focused on minimizing and reducing vulnerabilities in terms of migration. And also, we saw that the Mexican state somehow undertook to address and reduce vulnerabilities in migrants, both for Mexican citizens and non-Mexican citizens. On the other hand, this type of definition that is part of this international framework between the Global Compact on Refugees and the Global Compact for Migration somehow retake certain items that my colleagues have already shared with you today that I would like to highlight: the segregation and the classification of the different, and I quote, types of migrants. So this presentation in this context will refer to migrant because I do not really would like to use a lot of words to refer to the same thing. But in this context, when I say migrant, I mean those migrants who are vulnerable, they're not protected by the society, or the fact that there is some sort of lack of resources, whether internally or externally, for them to be able to enforce their human rights in full or to the fullest extent. And this includes undocumented persons. And also in the case of, let's say, deported or returned individuals or persons who, in consideration of their age or situation, are somehow disprotected. So we also include those persons who are subject to international protection. What are the social determinants of health and an appropriate standard of life? This may be different for migrants depending on their active migration situation. In this case, we're trying to understand and frame the considerations that need to be taken into account whenever we think of social security and other types of social benefits that we can give to migrants that are in a situation of vulnerability. For instance, in the legal domain, we know that we have a lack of civic power, specifically for those who are undocumented, and they may be limited or restricted in terms of having access to justice proceedings. In terms of the financial or economic aspect, we know that it is difficult to integrate them to the labor world, and they have limited access to credits, loans, and savings accounts. And in the social aspect, unfortunately, we see xenophobia and discrimination and a lack of social bonds, as these individuals are in a place where they were not born. Also, in terms of health and well-being, we have many subjects that we could also highlight as the determining social factors for migrants. These may differ from one person to another, depending on whether they are in a place of origin, let's say a limited access to healthcare services. As my colleagues have already mentioned this, limited access to sanitation and hygiene. This is basic. This is something that we retake during these pandemic times and that we're in right now. And not necessarily they have a land or house of their own or property whatsoever. They're highly exposed to criminality and violence and human trafficking. This is specifically in the context of violence that they may face during their immigration journey. They may also rely on social resources or subventions for food. again, we're talking about access. Whenever we say access, we're not only talking about economic access, but full access to the fullest extent in terms of the economic, physical, and social aspects, specifically for food security or insecurity in this case. One of the main pillars of an appropriate standard of life is related to this food security. So the definition of food security is what we all seek. This is the full access, physical, economic, and social access to safe food, nutritious food. On the other hand, food insecurity as well. This is what we're trying to prevent.
Whether it's limited or uncertainty of foods that are nourishing and adequate, or the capacity that's constrained to buy just the adequate food in ways which are acceptable socially. The lack of social security is an indicator that measures access or the adequate access to nourishment. And it's important for us to get closer to compliance. Make it compulsory to comply with law, with the indicators. This is our indicators for any person, and it's applicable to migrant situation. Let's think about the lack of food safety for migrants in transit. I mean, there's two case studies that are the point of reference and there's also documents that have in their content anecdotes. Our people, our migrants are suffering hunger or famine in their transit during their migration. There's studies by Aragon Gama, our professor, and Dr. Infante as well from previous years, as well as other studies that have been built with other data that have led us to think about food safety in society and immigrants. Now, we ask ourselves the question about food safety or that security with international indicators. What levels do our migrants in transit have to live through in this social context? In this study, led by Mr. Infante, Dr. Infante, we asked ourselves that question. And during March 2012, right before the start of the pandemic, in a shelter of migrants in the northern region of Mexico, we carried out this study with mixed methods to make the measurements of access, the economic access to nourishment or food. We have quantitative data that's food insecurity experience scale that's used by the Food and Drug Administration or the FAO, this agency, and the numbers have three-fourths of the people who were migrants in the study were experiencing a lack of food safety, whether it was moderate or severe. That means that they lived that moment in which there was a decline in the quality and quantification of food or nourishment eaten by them along their journey. This is something that worries us. Once again, this is not full factual or representative. It's not representative hard data of all the populations there, but we can visualize in this slide that almost 75% of the group of the population that's suffering food safety there, because we compare what's happening in all Mexican territory. So we have only a 4% of people living this lack of food safety. If we think about the poorest segment of the Mexican population, these numbers reach just a fraction of what we have analyzed as part of a research in migrant population. There's layers of social vulnerability. The poorest layers are indigenous populations, urban and indigenous. So we see that the numbers of food safety are not reaching the levels of the calculated estimations or numbers of migrant people who are in journey in their transit. So it's a sample of the population that's extremely important, which mirrors the economic capacity or access that our people have for food. In the quantitative studies, we see that there are strategies, schemes to make front to what's happening here. Some strategies are reserved for emergencies in transit. in the diagram there, you can see the boxes of the different strategies that allowed us to make front to this, used by the people who are interviewed by us, being their status in migrant status. So here we see the proportion of the different groups of civil society as it being the source of food and nourishment. I mean, stakeholders such as civil society were stakeholders that we had to ask food from, and some people just simply held their hunger, had nothing to eat, and they just have to bear their hunger or famine with kids, making us visualize that it was extremely important for us to see that the bigger the families, they would take care of the hunger of the youngest in their family nucleus. Some of those are strategies associated to emergency or humanitarian emergencies such as this. To summarize, what we found here succinctly is a pattern that worries us, a pattern of food safety issues, a lack of nourishment for migrant people who are in their transit through Mexico. The main stakeholders that have the right to that level of life, and if we center our discussion on food and safety, there's many stakeholders involved: shelters, other NGOs, civil society agencies, international agencies, and individuals have been part of it too. As we've mentioned before, we've asked different stakeholders from the public and private sector to be part of this. Before the pandemic, we spoke about the general scope or landscape that we were analyzing. We asked the public sector stakeholders who are important to participate, like the Beta Group, the integrating centers located in Tijuana and Ciudad Juarez, which offer services for people who are migrants. And more than this, if we take a step back to see this worrying pattern, is the proportion of the services that are offered in one sector versus the other. The private sector stakeholders, I mean, I'm not saying that they're not contributing, but the or the private sector, NGOs, OSCs, have taken on the bulk burden of the services and attentions that they pay for the well-being of migrants who are in transit. Sorry for interrupting, but you have 3 minutes. Thank you. So, if thinking about COVID-19 and the context and how this whole setting has changed, we can analyze point by point the consequences of COVID, the impact it's had on the well-being of migrant people and their vulnerability. We focused on the effect of COVID-19, the impact and the response mechanisms to make front to COVID-19. There's the terminating decisive factors that impact health in many ways. Of course, there's COVID-19. There's the condition. It's been documented by the states, by different independent stakeholders from civil society in various sectors of the migrant population. Unfortunately, the numbers of the public sector might not mirror or might not communicate what's being seen in the complex migrant situation in the country. New policies are substantiated thanks to national security, and there is an incremental documentation of cases of xenophobia and discrimination, which has been mentioned as referenced by Mr. Infante prior. Now, there's vectors, or the migrants are seen as vectors for the spread of the disease. There's a loss of income that's been mentioned by the OIM, being this data documented at the beginning of the pandemic. This has been measured in members of the migrant groups. The policies that protect these groups versus COVID-19 are not necessarily taken to exercise, because there might be people in these that don't have their own house or asset. Now, we have heard what my colleagues have mentioned, and I, along with Ms. Valeria Marina Valle, our Dr. Marina Valle, we held a set of interviews. We interviewed leaders and other OSC leaders and stakeholders that enabled or facilitated access to benefits to migrants. We analyzed the institutional capacity to give service to to our migrants. But there is like certain levels of confusion or misunderstanding with healthcare workers about the benefits that the beneficiaries, being the migrants, could receive. They didn't know, the healthcare workers didn't know if they could give them the services or not. There was a closure of formal networks of support, which is an important consequence of what's happened. There's an direct impact on migrant segments of the population amidst the pandemic. We do not know how many agencies that provide services are open or not. Some say that there's 90 or 130 shelters that are part of this incredible, wonderful, complex network of shelters and points of service and attention in Mexico. At some point back in October of last year, we estimated that 23 of these shelters were partially operating. We do not know at all times what's the dynamism that they've gone through, or in which centers have provided services or not. We know that some shelters have had to close their doors completely due to reasons which, because of precautions, because they've had a spread of COVID in their centers, but the majority have been seen in the borders areas with partial services. The centers have provided partial services, so this has been mentioned by many OSCs. An example that dates back to June last year, it's part of the document. And in the document here, you can see that there is the list of services that were not being provided amidst the pandemic: psychological attention, medical services, while also hospitality and other services. And if these services are not offered, they impact the well-being. We have the need to obtain more data to know how accountable, how we're all accountable and must comply with the rights that there, we have the migrants of population trying to have access to the benefits for health. We have indicators to measure data to reach the food safety levels that are required. We have constituted a work table that is centered on analyzing food safety with Mr. Dr. Infante, Ms. Bojorquez, and other colleagues from different sectors. We're all working together to obtain more data and knowledge due to the events. There's different journals that have published some information. Our objective is to develop an instrument or draft an instrument to measure economic access, correlating it to food safety or nourishment. We need to continue studying, researching to draft public policies. So just my closure for you today is that my insights. Amidst the pandemic due to COVID, I'll tell you that some responses have affected in a disproportionate way the migrants of the population, not providing the mechanisms that are required to make equity or the principle of equity lead them to have access to services. The social protections constitute mainly the mechanisms of rights and access to nourishment and much more. Our advice, our list of advice is here. So we highlight some points thanks to what we've done with me and my colleagues. We strengthen the multi or interinstitutional cooperation with the ODS 17 and the SDG. We are supporting NGOs or civil society agencies which are expert in the subject, trying to simply not reinvent or find the silver thread. Or we want to continue our research, discuss these matters with our experts, share data, and support society that has been providing for many, many years attention, services, guaranteeing the rights of people who are migrants. We have to think of migrants who are elements that must be considered in our response mitigation plans and guarantee economic, physical, and social access to benefit migrants, always considering the same dynamism, understanding the dynamism and the profile of migrants that pass through Mexico. There's more and more, so more women and other subjects who are subjects of international protection, we have to be inclusive and sensitive enough and understand and make the healthcare workers be sensitive enough to harmonize all our efforts to those local, regional, global goals. We need to be inclusive and make sure that our migrant populations have access to the social protection schemes to be in compliance with our laws and regulations, to be in compliance and achieve the ODS 2 and 10, which are international goals when it comes to well-being. With this slide, I close my presentation. I hope we have more time to talk about these subjects during the Q&A. Here's my contact information. It's my email. I'm open and I'll receive all your communication. Thank you so much. Thank you, Caroline Deschak. Thank you. And for the sake of time, I'll go start immediately the third presentation. We have Mr. Tonati Gonzalez, who is an expert on medical science, thanks to you. He's also a member of the researchers in Mexico Level 1, drafting public policies, thanks to the Metropolitan University in Georgia. And in Morelos, his dissertation was a transference of remittances to locals from other locations and the obstacles that they face, in the immigrants face in the U.S. territory. Here we have the Institute of Mexican Population. Our doctor has participated in over 19 projects focused on health and worked with other international institutions like the University of Minnesota, DePaul University in Chicago, and the Institute for Public Health and Infectious Disease from North Carolina. During his professional development, he's also had experience on qualitative group analysis in different states of Mexico, state entities abroad in Chicago, Carlisle, and LA, and many Central American countries except Belize. His presentation will be taking place with the participation of Mr. Lilian Martinez, who's worked with InHealth with Mexican population in Georgia with the U.S. during the COVID-19 pandemic. And lastly, we have the participation of Lilian Martinez, who's a psychologist, thanks to the campus in Oaxaca of University Golfo de Mexico and the Hellstad Institute in Oaxaca. She has a master's in psychological development and children's psychological development and other accreditations in social sciences and behavioral sciences. She currently works in the healthcare services in the state of Oaxaca, and she has her clinical private practice. Lilian Martinez will be presenting the following data with Dr. Tonati Gonzalez. The floor is yours.
Es que no podía abrir mi micrófono. Sí, aquí estoy.
I'm here. I couldn't enable my microphone, but I want to know if you can see my slideshow. Yes, we can. Well, thank you very much for inviting us, first of all, and it's a pleasure to share with the rest of our colleagues, panel members, friends that we've known for many, many years. We've been discussing the same subjects, which is international migrants. So I'll explain what I have to explain in no more than 10 minutes, and then Lily will start. I apologize ahead of time if you hear some sound, they're pounding or using hammers in the neighboring, building. So we're going to be talking today about an initiative, a healthcare initiative that was developed by Professor Lilly to obtain her dissertation in public health and behavioral science. That I was also in that field. It's a part of the strategies or initiatives that she implemented in Georgia, U.S. last year, and later on she's going to be talking about the detail. I'll just speak about the intro. As you well know, Mexico is one of the countries with the greatest number of international migration in the world, and the majority of Mexican immigration is centered, or Mexicans immigrate to the U.S., and they estimated that by 2017, they'd have in the U.S. territory over 12 million Mexicans, out of which 5,600,000 had no documents. And back in 2017, we estimated that out of these 12,200,000, a high percentage of them had no access to the healthcare services or benefits in the US. So we're talking about 3.8 million Mexicans that did not have insurance, medical insurance in that country. So I don't know how much of this you know about, but here I'll briefly define what you see in the flow of health or in the we have projects in part of our project includes the rights and defense of human rights of immigrants, and these projects were kicked off in 2003. They're agencies that work between ministries. It's interinstitutional, cross-institutional efforts with the ministries of health. And there you can find these windows of assistance in in embassies or consulates or diplomatic representation units in the US territory are there. This initiative is an international initiative. I mean, that's been used in Central America, or they've based our project, they've mirrored our project in other places. With these hold on. In these special areas or units we have access to diagnostic data. Our people can approach them and receive a service. They're not managed by the Mexican government. They're working in a collateral way. They're health care ONGs or universities that have their initiatives and implement those modules. They can give them advice, consulting to people that approach them. These type of modules are present in LA. Some of these modules have a mental health care unit, not all of them. It's not a constant. Each healthcare service unit there has like another area for healthcare services with the NGOs that are part of the initiative and have the expertise. Some modules have these subdisciplines constantly and some don't. There's other stakeholders like NGOs participating there. This is more or less what we've done, or this is the LA unit. Our counterparts or our people go to these modules or units to check their documents, IDs, or receive certain services. They stay there for many hours so they can receive more information. We give them some leaflets, some posters, some banners or info. We can give them some diagnostic data about their conditions. It's clear to us that these units have specific windows in which we exercise the initiative to increase their health. These are efforts without borders. You know, we extend these efforts in other countries. We have some constraints. We have a scarcity in our modules, scarcity of budgeting, scarcity of human resources, and each unit or discipline that's present in this healthcare services that we provide depend on NGOs or other stakeholders that are there present. And something that happens constantly as part of our research is that many migrants in Mexico don't know about the existence of these modules. Many of the people that approach these units have been in that condition for many, many years. But for those who have lived there for less than 10 years, don't know that these units exist. On the other hand, as part of our institute and part of the research institute, I mean, our center is constituted by researchers of many parts in the world, and we faced many obstacles. There's international immigrants, and for them to have access to the healthcare benefits offered by the country. In this case, we're talking about the case of Mexicans in the US territory facing the obstacles. I'll tell you that you can find or start a search and try to find budgeting from other countries, not only the country of origin. During the research that we've had in our institute, we have documented cases of Mexicans who are living in the US who are going through, like they have remote uh, appointments with physicians, and the physicians in their country of origin give them a prescription drug. They send the prescription from the physician via some carrier services. They can then buy their medication. They cross the border to buy the medication or house remedies to get some services. So, but it's like, it's not an exception. If we systematically analyze what's documented, and I think Cesar Infante has also researched this, what I've just mentioned happens everywhere in the world. It's like common. Part of the immigrants try to find medical attention and back in their countries of origin. So why draft a cross-national, transnational healthcare initiative? That's why I told you that there's different migrants from different migration circuits and belts that are using the healthcare services in this, cross-border services. They can access, for example, certain services in their original country and not in the other country. In the US, there's a lot of Mexicans that don't have access to medical services. The private services in the US are very expensive, plus the language is another constraint because many Mexicans don't speak Spanish. Many are fearful that they don't contact the agencies to obtain the regular service. So, in general, I mean, that information, for example, sometimes some people fear deportation, when they try to approach like an institute or agency. There's other experts that speak of the fact that there's a lack of cultural capacity or the level of professionals who are competent, and then that lack of capacity creates frictions, and then Mexicans don't feel at at ease when receiving services from like an institution. Mexicans are looking for or miss the services that they receive back in their origin. But migrants is one of the segments of the populations that move often, so we're talking about areas that have certain restrictions. We know that some workers of Mexican origin have long shifts. Some have 2, 3 shifts. Some work Saturdays or Sundays. And during Saturday and Sundays, consulate is not open. So we think about the healthcare services that are offered to them in the U.S. Like they don't have like an embassy or some grounds that they could go and ask for services to be provided to them. For example, those who are Mexicans who are in Georgia or Tennessee would have to go to another. Um, Hold on one second. I think I have to interrupt you. You mentioned that you had 10 minutes. You have 1 minute left. Some of the studies specify, I mean, that you think about what's happening on the day-to-day life of the migrant population. We have submitted some proposals. We incorporate the transnational strategies for e-health to give our Mexican population mental health and health in general. And lastly, what I'd say is this: we have documented these recent studies. We know that there's been a greater impact on immigrant workers during the pandemic. We know that the impact on mental health affected a lot of our population. It affected greatly the migrant groups or vulnerable groups because they were confined, affected in labor. There are people with post-traumatic stress, depression, stress, and anxiety, and chronic diseases. I mean, there is a low income, so that increased chronic diseases and other points. There is a lack of information, of COVID information being translated. It made it difficult for the migrants to have access to healthcare systems. So there's also some fake news or data that made all the channels of communication and social media worser. Amidst the pandemic, we know that the mental health issues increased in vulnerable groups, especially speaking about the migrant Mexican groups. That's what I've had to say. Lily, thank you. Good afternoon to all of you. Can you hear me? Yes, we can. So I'll continue because I'll talk to you about how we developed or kicked off our initiative and how we reached the phase of implementation. The objective of our study was to design, implement, and assess the intervention in education to foster the protective factors of mental health. And along with this initiative, we needed to foster and strengthen, what through e-health, we needed to protect the Mexican population in Georgia, USA. Next. Which are the protection factors of mental health? All of these situations that make the people have a decline and suffer an issue that's mirrored in families, individuals, communities, institutions, included in the individual factors are the ones that we are trying to work with. I mean, they're all subdivided and they're divided into the following. There's factors that are applicable for teenagehood, adulthood, being senior in our years. There's factors in the individual groups that have been object of the study. Now we have to give ourselves more tools to prevent and have a decline in the numbers of mental health care issues. We focus on the capacity to adapt, social networks, and healthy habits. As I've mentioned, to achieve this, we needed to have our people we needed them to have like the capacity to face or have the skills to face the situations and to simply see the complexities and the lack of complexities of the new situation with COVID, to face all the emotional losses that our people could face. Because when somebody migrates, they leave their original country and they meet another one. They need to manage their emotions and stress correctly. And we added another situation, which is the management of anxiety, because there's studies that prove that one of the symptoms, it's one of the symptoms that's seen in the majority of our migrants. The method that we used in the study was pre-experimental, pre-post intervention in our measurements. We had qualitative methodology, educational in our VDS. We had our population from Atlanta. The study started in October 2019 to August 2020. It was the peak amidst the pandemic, the acute peak amidst the pandemic in 2020. The recruitment process of the members or the sample of the study. We recruited them during January, February 2020, prior to the pandemic. The members who were recruited went to the consulate. They were given specific sessions in which we focused on mental health. We glued banners in the consulate and uploaded our data in the website. We recruited 34 people, part of our study, who were interested. These people should have certain properties or characteristics. They should have been over age or no clinical or mental history. It was important for the recruited members to simply not be using any medication or psychotherapy. We confirmed the participation of 24 recruitment elements that assisted to 11 sessions. We only had the participation of 11 out of the 24 people. Along the way of the study, we lost a few. And some arguments of our people were the long shifts that they had to work that did not enable them to come to our sessions. And they didn't want to come to us because they didn't have their documents or green cards, and they have that fear to be deported or something. So they had to manage the video conference remote platforms for the sessions. We focused on this project during January, so it was at the beginning, and then the boom happened of the use of remote video conferences and the management of social networks and means as the pandemic evolved. During our evaluation, we had the interviewee being interviewed by pre and after, and the evaluation of the whole process of their participation. The profile of the recruited participants was constituted by the following. It was constituted by 70% of these 9 were active during the session and pre and post assessment. They were 8 women and a man with an age average of 39.8. The state of the person was married with kid. Schoolings was only the level of middle school. They were housewives mostly, and their migration status was more often people that simply had no documents. They didn't know if they had coverage of psychiatric services or psychological services, even though they had lived in average 19 years in the US and lived in different counties of Georgia. Next slide, please. In the education sessions, there were 10, 3 out of which were remote. Then we had a fusion of the group of recruited members. We had 3 sessions, and out of those 3 sessions, we split the group into 2. Some were remote conferences, some were face-to-face. After the 4th session, from the 4th to the 10th session, the recruited interviewees were part of these sessions in the video conference platform, and I was based here in Mexico. This is why the initiative was transnational, cross-border. So we executed this initiative that way, with that method. We had the protective factors considered and the strategies to make front to the situation, which were one of the instruments that we used as part of our discussion in the subjects. Now, what were our findings? Previously, in the educational sessions, the recruitees or interviewees specified that they had almost null strategies to make front to their emotion management. The emotions that they lived was fear, sadness, and anger. When they managed stress and anxiety, we quote the following, and I quote the what gives us or sets the example of the difficulty to manage those feelings. And after after in our findings, we focused on the emotion of fear, because the fear was the strongest feeling that they felt intensely. They feared being deported, the lack of being regulated subjects, the lack of security with their significant others, extreme sadness, and other worries. But we add to these emotions fear of losing one's life amidst the pandemic. Nobody really knew what was happening. And if you can see here in the instrument, there's another case that's, and I quote, they didn't know why so many people were buying toilet paper, and our people, part of the study, had certain confusion when they saw all of this happening. After the educational sessions, they said and made reference and specified that they use certain tools to manage stress and anxiety along with their emotions. In the study, the person of the study was capable of integrating to their life a strategy that they learned in the educational sessions that we held. And there the person explains what she's doing, how the strategy is helping her, and how she is implementing everything that she learned during our educational sessions that helped her control her emotions such as stress and others. Next slide. The protective factors considered as part elements for mental health. In the education sessions that we had, we considered the networks of support. They had the capacity to create those bonds and have the routines in place to strengthen mental health. Confinement amidst the pandemic affected physical contact or interaction amongst peoples, as we know, reducing our contact to the core or the nodal family. Now, even though these people, part of the study, faced a difficulty trying to relate to others, they tried to keep their bonds or links in a remote fashion. Here we have another case. They had to face the conditions. Us as a group had sessions weekly at 7 p.m. Mexico time at 6 at Atlanta, but we shared during these sessions our emotions, our experiences, everything that happened on a day-to-day basis, and we learned techniques to manage emotions and states. The group was a representative sample of an emotional contention method there, with and we knew that even though we couldn't broaden those sessions or the network physically, they found that support that was something that we saw in the group. Before, even if we had a few in our sessions, some said that they mentioned that it was very important to take care of their mental health amidst the pandemic. They expressed their feelings of fear, anxiety. They were trying to simply not add more pressure, well, sleep 8 hours, take a sun bath, sleep right, sleep enough time. And you see what all these people were doing to try to develop healthy habits to build their mental health. When it comes to adaptability as the theme during the sessions in the assessments post and after to face the situation such as the pandemic leads us to quote the rest of the case of the samples here. That our people in this study use certain tools that they obtained through the education sessions that we had with them. Next slide, doctor. As a conclusion, the importance of the implementation phase of our intervention in sessions to increase mental health is based on the analysis of mental health issues that the migrant Mexican population had already experienced. And we add to these problems the other elements amidst the pandemic, amidst this adverse scenario or context. So the implementation of our initiative, our intervention really triggered or fostered mental health in this group of migrants. We achieved our objective, the objective that was the frame of the study. COVID-19 was completely unexpected, but it was a matter of discussion throughout all our sessions. You know, after it was an element that made it us understand that our effort was making it feasible to increase the mental health of our migrant groups. As observers, we know that it's important for us to know which are the resources or instruments we have, such as remote platforms to communicate. The strategy was but it received the budget, and the budget was correct within reason. And what we talked about amongst ourselves as doctors, I mean, we were Mexicans, they were Mexicans, they identified themselves with us amidst their context. And our group, our sample, in our group, they were capable of expressing, trusting us. They spoke Spanish to us, and we understood perfectly what they were saying, and they felt identified because we are Mexicans, we are people, and that's part of our intervention, and that's how we participated. Doctor, I don't know if you'd like to add a few words. I finished.
Thank you so much, Lily. Just to wrap it up, I would like to thank you. This is our contact information in case you would like to contact us. So Lily, she has got her bachelor's degree since last year, actually. But our student Mariana, she's actually in the call today. She is here today with us in this presentation. She's following up on this, and she's also just having a strategy to promote mental health with female carers, girls and women who have autism in California and Arkansas. So we are, let's say, in phase 2 of these initiatives. And that would be my final remarks. Thank you so much, Dr. Tonatiu, Madam Lilian. So we would like to provide you with all of the questions from the audience in consideration of the time. So I would like to thank you, everyone, for just allowing ourselves to just share comments with you in this webinar on migration and health. This is what the participation of the audience. I would like to just thank the CS group for allowing this to happen. And I would like to also just open certain words of Mr. Machado. We say that migrant, there is no path unless there are stars in the sea.
La doctora Daisy Corrales.
Pantalla. Gracias. Bueno, agradecer a los
Thank you. We
ponentes
would just like to thank the speakers and participants for taking part in this work session from the Inter-American Center of Social Security Studies. We had certain priorities in terms of migrations and the different studies that we could conduct just specifically to strengthen public policies. We know that the main issues or the topic and subject of migration is somehow based on a bipolar discourse. This means that this discourse is also referring to the fact that whenever the economy is good, then we know that migrants is just a source of work, of labor. We know that in the US and other countries, they work through migration. So whenever we are in a poor situation or in a situation of crisis, then we know that, of course, migrants are not really that well defined. So we know that we had all different types of services provided by them. We know that they are humans who provide these services and they are, let's say, less expensive. So we have focused mainly in this situation today that we are in amidst the pandemic. We know that migration is an issue. That's how people is approaching this. And we even see that is actually one of the main triggers of this pandemic. This is quite a complex situation. So we also saw that experts today are talking about this subject. We're talking about all of these aspects that are related to the economic, physical, mental health sides to it, and all of the cultural aspects as well. So we may also say that all of the social determinants of health somehow lead us to a process where we are amidst a set of complex situations, specifically in the border. We have seen shelters, healthcare services being provided. So we need to just really protect this access to healthcare services. As we were mentioning at first, we need to make sure that this is a reality. We have a public health issue, a human right issue in front of us. So we need to work with a structure that somehow needs protection for us to be able to just provide all of these healthcare services. So we need to just overcome all of these hurdles that we have seen. And well, what we're trying to do is just to unify this healthcare provision nationwide, but also internationally speaking. So as for access to services, we are in a process. As we already discussed it here, we know that public policies are not the issue as such, but the fact that these public policies are only written in paper, we need to put them in practice, to have them in place in all political scopes. And we know that we as service providers as well, we need to get the funds for us to make this possible. We have discussed this internationally amidst many countries. We know that there are differences from one country to another, so we need to really address all of these matters. On the other hand, we need to have, let's say, some sort of actions that can allow us to protect them. We need to enforce all of these rights internationally. We know that we have talked about this many, many times. I would like to restate this. And this is the fact that we have really addressed a lot of human rights issues, and this goes beyond the different powers of a certain institution, and this needs to be taken to the international level as well. I know that experts today have provided us with their broad experience. At least here in Mexico, you have seen that we have high concern in the state, in the community. We know that NGOs as well are also concerned because we believe that this process needs to be centered on individuals, on families, and on a collective side as well. We are also crossing borders. We are human beings who are in this situation. And we know that a group of migrants is one of the most vulnerable groups there is, and they need this type of special care. So this is one of the many working sessions that we're going to have. So I would like to thank you for taking part in this session. In the event you have any other questions, comments, you can just contact us at our email addresses. So thank you so much for your kind attention.